Most right-sided valve disease you're going to see is going to be tricuspid regurgitation. So mild tricuspid regurgitation is normal, but we can have tricuspid regurgitation because of an abnormality of the valve itself, so it's rheumatic or it's prolapsing or there's endocarditis. But we can also have tricuspid regurgitation because of an abnormality of the right ventricle or if there's pulmonary hypertension. And sometimes a pacing lead through the tricuspid valve can disrupt it such that it becomes regurgitant. So this is severe tricuspid regurgitation. Look here at the neck of this jet up at the tricuspid valve. We can see how broad that is. So there's some other things we can do to assess the severity of the tricuspid regurgitation. So here we've put a continuous wave Doppler through the TR jet, and we're going to look at the characteristics of this jet here. Now we need to remember that the velocity of the jet isn't giving us any information about severity. It's just telling us about the gradient between the right ventricle and the right atrium. So instead we're going to look at whether this waveform here is complete, like it is here. We've got a whole signal. And we're going to look at how bright it is here and compare it to forward flow. So I think I've got a complete signal. I think it's pretty intense. I'm suspecting this is probably going to be severe TR. The shape of it is still quite U-shaped. Sometimes when you get very severe TR, you get a triangular shape. This is still fairly U-shaped, but I think this is probably going to prove severe, but we'll keep looking. So this is a subcostal image where we're focusing on the IVC and the hepatic vein. So here you can see the IVC, and this is a hepatic vein draining into the IVC. This is the right atrium here. And when we look on colour, we can see this really broad, severe jet of tricuspid regurgitation. And it's so severe that it's actually going backwards up the hepatic vein. And we can see that because we're scanning from up here, so we know the flow towards our probe is going to be red. And we get this red flash here, which we call reversal in the hepatic vein. So we're going to use the information we've got to decide how severe our TR is. We had a very broad jet, didn't the neck width looked much more than 7 millimetres. Our signal was pretty dense. It wasn't triangular, but I think the intensity was more than moderate. And we had quite obvious systolic reversal in the hepatic vein. So I'm quite confident that I can call this TR severe. So now let's think about tricuspid stenosis. It's very rare. But not only is it rare, it's actually really difficult to spot as well. It's mostly going to be rheumatic, but you don't get the thickening on the tricuspid valve that you see on the mitral valve. So if you have rheumatic mitral stenosis, don't forget to check the tricuspid valve quite carefully. Occasionally, a pacing lead through the tricuspid valve can become enmeshed in it and cause the valve to become stenotic. So suspect tricuspid stenosis if your forward jet on colour looks narrow and if the mean gradient is more than 2 when you trace around the forward signal. Pulmonary stenosis is usually congenital, and we often see it with other congenital abnormalities. I think it's easiest to spot using colour Doppler. So here we've got colour with the pulmonary valve. You can just see the bifurcation here, and then the main pulmonary artery is here. And what we've got is lots of turbulent colour in the main pulmonary artery. If we put continuous wave Doppler through this, we get this signal, which is about 2.5 metres per second, so it is raised, but it's suggesting there's only mild pulmonary stenosis. And I think if you look really carefully, it actually looks like the stenosis is above the valve. Most of the turbulent flow and flow acceleration is actually starting about here, but this is only mild. If the peak velocity was 4 or more, we would consider it severe, and if it's between 3 and 4, we would report it as moderate. It's really important to remember that if you've got pulmonary stenosis at any level, whether it's at the valve or above it or before it, you can no longer use your tricuspid regurgitant jet to help you estimate pulmonary artery systolic pressures. So this is pulmonary regurgitation. We've got a parasternal short axis view, and what we've got is a red jet backwards up the PA. So we're scanning up here, so any flow towards the transducer in red is our pulmonary regurgitant jet. I'm looking in the jet here in the main PA, and I'm looking to see how much of it fills. So it's almost all of it actually. So it's probably about 80% of the diameter of the PA has this regurgitant jet. They are quite easy to miss because the velocities are low. There isn't the turbulent flow that we will see with a regurgitant jet from another valve. So this low red signal here can be quite easy to miss. So we can do some other things to make sure we don't do that, and we can put a continuous wave Doppler through that signal, and we can see here our forward flow through the valve, and this is our PR. And if we measure the pressure half-time of a regurgitant jet and it's over 100 milliseconds, it suggests our PR is severe. So right-sided valve disease isn't as common as left, but don't forget to look for it because it's actually missed more often.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.